You're tuned into the Unnecessary Harm podcast, where we drill down on issues of substance use and its cultural impact. Your host, Shane Varco, Executive Director of the Delgado Institute, with over 40 years' experience in youth and community work and a passion for building resilience.
Welcome back to the Unnecessary Harm podcast, and a special welcome to those who may be visiting us for the very first time. Welcome on board. Our very special guest today on the Unnecessary Harm podcast is not only a 30-year veteran of pain medicine specialist, but also a cannabis science certified practitioner through the University of Colorado, the state in which he practices. He's board certified in physical medicine and rehabilitation since 1995, pain medicine since 1998, and pain management since 2000. He's a volunteer clinical instructor for the University of Colorado Medical School at Colorado Springs. He is a former president of the American Board of Pain Medicine and has served on their exam council for over 20 years. He served on the Colorado Governor's Task Force on Amendment 64, which legalized marijuana for recreational use, Consumer Safety and Social Issues Work Group in 2012, and served 4 years on Colorado's Medical Marijuana Scientific Advisory Council. Yeah, I'm going to take a breath, people. Just give me a minute. He was an invited speaker to the United Nations Commission on Narcotic Drugs in Vienna in March 2023. He has testified to the Canadian Senate on their marijuana bill in 2018, as well as the New York General Assembly, and speaks internationally on the health impacts of marijuana, including being an invited speaker to the Mayo Clinic, Jacksonville, the Royal College of Surgeons in Ireland, UCLA, Virginia Medical Center, and too many others to mention. Seriously. He works nationally with other state legislators considering legalising marijuana for medical and recreational purposes. He is editor of Cannabis in Medicine, an evidence-based approach since 2020, and currently the co-vice president of the International Academy on Science and Impacts from Cannabis, which is an exceptional platform I use regularly, which is now a member of the VNG, I'll get it out, the Vienna Non-Government Committees on Drugs. Dr. Ken Finn, welcome to the Unnecessary Harm podcast, my friend.
Thank you, Shane, for having me. Good seeing you
brilliant
again.
Having you on. Yeah, absolutely. Yeah, we met, I think, face-to-face for the first time in Vienna. It was in 2023, so that was great. We had, obviously, dealings prior to that. Yeah, but good to have you with us today. And yeah, now, there's a really good reason for that long intro, and I think it's important. Sometimes we can waffle on for self-aggrandizing purposes, and that wasn't the intent here. I really wanted our listeners to get that you get this. I mean, this is an arena you've not just dabbled in, not just a partisan to. You are entrenched and immersed in this space. So you got a really good handle, both nationally and internationally, on this issue. And I really wanted our listeners to get a handle on that because you get it. And I think that's important. And those listening today need to understand Dr. Ken's perspective is an exceptional one and it's evidence-based. So, kick us off. What was the main reason you decided as a doctor, with lots of options available to you, of course, from GP right through to specialist, what was the main reason you decided to specialise in pain medicine?
Pain medicine was something that I just kind of gravitated to. And I think in having practiced medicine for so long, I honestly think that the fields of medicine choose the physician rather than the other way around. I think, certain personality types or end up in, for a neurosurgeon, for example, was kind of drawn to that for many reasons, and orthopedic surgeons, pediatricians. I mean, there's kind of a personality type, and that's kind of what I gravitated to many, many moons ago.
Okay, so I like the discipline chooses the physician. I think that also has merit for our listeners as well. I think that's important. So, of course, cannabis is medicine. It started to get some public momentum when the pro-cannabis activists such as NORML switched tactics on their legalisation agenda back in the mid-90s. I still remember watching the cannabis use graph drop in the 70s. It was huge. Cannabis was a major problem amongst other drugs. Of course, the whole Cheech and Chong era was, for those old enough to remember that, they were the rock stars of weed. So this was huge. And of course, in the 80s, there was a real pushback against drugs, and we saw a massive decline. And then down into the mid-90s, where marijuana was plummeted to one of its lowest use levels in US history. But then this tactic was employed. And it got traction. And so all of a sudden, NORML, among others, decided to tout cannabis as medicine. and therefore if it's medicine, ultimately it can't be that dangerous. So was that in any way an influencing factor to you? You came into the discipline a little bit later than that, but did that sway you in any way?
Well, number one, my interest and involvement in cannabis was not a career choice. I mean, I'll just be honest and upfront. Back in the 80s and 90s, like you said, with educational campaigns and the perception of harm was at its highest, I believe, at that point. And then, like you said, around the mid to late 90s, I think when California, for example, first legalized for medical purposes is when the pendulum swung. Being in Colorado from 94 until the early 2000s, it really wasn't on our radar. I know they talked about it at the state level. And then in 2000, the state of Colorado voted to approve it as a medical purpose. And it just kind of lied dormant for many years because there was no infrastructure. There was no dispensaries. There were no growers. There was no patients didn't have a place to go. And I think physicians had a reluctance to recommend its use because of fear of prosecution or litigation from the state medical board. But in 2009, that's when things really ramped up. And that's when I saw a lot happening in my own practice where I'm like, what's going on here? Because, in 2009, after a lot of politicking, then the dispensaries and the infrastructure opened up across the state where, currently we have more marijuana dispensaries than Starbucks and McDonald's combined in the state of Colorado. It's easier to get marijuana than it is a Big Mac or a latte. And so what I started to see were increasing numbers of patients presenting to my office on opioids, which is a whole other discussion, and it's a big problem. And they were reporting very high levels of pain, and they were using cannabis for their pain supposedly. And it didn't make any sense to me. I'm like, well, if cannabis was such a good pain reliever, why are you on your opioids, and why is your level of pain so high? So I started doing my own research and reading and educating myself because the data has been around for many years, but the products have not that we have today. These are a new generation of products that are available to people in the U.S., particularly in Colorado. So, and then when I pinned my patients down and I said, okay, well, we don't like co-prescribing benzodiazepines and opioids because they're both centrally acting. I don't endorse using cannabis and opioids for your pain. So what do you want to do? If you want to use your marijuana, and go for it, and I'll taper you off your opioids and we can part ways. And most of I'm saying nearly 99% or more of the patients said, no, I don't want to stop my opioids because they help. And I said, well, what about the cannabis? Oh, well, it doesn't really help my pain or what I'm seeing you for, but it helps me sleep or not care. And that really raised a flag for me. And that's when I took a deep dive into cannabis as a pain reliever. And the data just hasn't been there let me rewind. From a molecular and scientific basis, there is evidence that there are analgesic properties or pain relieving properties to components of the plant. For example, we've developed Marinol or Dronabinol back in the late 80s for chemotherapy-associated nausea and vomiting and weight loss related to HIV and AIDS. So we've had synthetic THC forever, but
Correct.
I've never had a patient ask me for that FDA-approved non-contaminated THC. And so it didn't make any sense to me. You know what I'm saying? So it didn't make any sense to me. So when I took a deep dive, the science, even though from a basic science perspective, there's something there, but when you translate that into real world products people are using, it falls completely flat. And even the Australian Pain Society, the New Zealand Pain Society, the Australian New Zealand College of Medicine, they published some nice reviews, and it just simply, the data has been completely absent as it relates to particularly dispensary or raw cannabis. It just hasn't been proven to be an effective analgesic or an opioid substitute. For example, Colorado in, I don't know what year it was, I'd say 17 or 18, in a midnight move, approved opioid substitution for the use of medical marijuana. And despite that, there's been a significant rise in patients carrying that qualifying diagnosis. But our drug crisis has gotten worse under the banner of legalization. It's simply not helping our drug crisis. I think the CDC data that came out recently, maybe we're turning the corner, but I don't think it has anything to do with marijuana, because I helped publish some papers over the past few years with Archie Blyer, who's a physician in Oregon, formerly a pediatric radiation oncologist or pediatric oncologist from MD Anderson Cancer Center in Houston, that fentanyl death rates are actually higher in marijuana states than non-legalizing marijuana states. So, these drugs play very well in the sandbox, and there's a lot of relationships between the opioid receptors and the cannabinoid receptors. They work very similarly. They're kind of like stable mates, for lack of an analogy.
It's interesting, that statement you made before. I think it's fascinating about the self-administering of cannabis and opioids. It's because it doesn't really help with the pain, but it helps me care less and sleep a little bit better. Well, we know from the science that's not, as a sleep aid, it's not a very good one. A lot like alcohol. It may give the appearance of helping you sleep, but it doesn't. But I am fascinated too. One of the things I wanted to just, before I go to the next question, to pick your brains, Ken, is that we've had, and I've watched this clinically as a practitioner in the space for the last 15, 16 years. I've watched this, but prior to that, I was very aware, because I work with a lot with young people over the last 40 years. I've been specifically, my arena is working with young people, and of course the culture around young people and substance use invariably becomes part of that culture, that whatever it looks like. So understanding what that looks like, how it fares, whatnot. But this stuff has been touted as the panacea of all ills since the late 70s, arguably, and with real impetus in the late 80s, early 90s. And the only reason this isn't allowed to succeed is because it's been blocked by all these do-gooding moralists who don't want people to get high. And that was kind of the rant. And they say, if you just give us this space, we will guarantee this is going to be fantastic. Now, we've had arguably 40 years, now let's say 30 years of solid, active engagement with this substance in various concoctions and iterations and manifestations. And in the end of the day, and you can correct me if I'm wrong, I'm happy to hear it, because this is your wheelhouse, not mine, is that the best we've come up with is a properly clinically refashioned Charlotte's Web called Epidiolex. That's the only new medicine that's actually landed under a pharmaceutical banner, properly clinically trialed, and I give due credit to GW Pharma, now owned by Jazz Pharmaceutical. They spent, I think, $1.3 billion and 10 years or 11 years of research to try and come up with a solution that was pharmaceutical grade to deal with Dravet syndrome, epilepsy, amongst others. And it has a 25% efficacy rate. It's a fourth-line treatment now, as I understand. All very nice, but after all that promise and after all that carry-on from its therapeutic capacity to cure everything, this is the best we've got. Yet alongside that, at the same time, as you've just indicated, we've got this chaos, this addiction mess that's burgeoning. So, I think that's really important. And I think now your expertise in this field is very hard to match, and clearly we've heard that. Now, you've indicated this, and I want to, if I can, if there's more you can say on this, drill down for our listeners from a clinician's perspective. You said I like the language in the same. It's in the same stable. Why isn't this working? Why and will more research? I'll keep talking to pharmaceutical guys and say, oh, we just do more research, and now there's something like $4.1 billion globally been spent on researching this stuff, and still we only got a PDLX to as a result of that. Is there, as from a not someone who's perhaps opposed to cannabis because you see its failings, but as a doctor who looks clinically at this, is there any real future for this as a pain management tool?
Not at this time. I honestly don't. And I think particularly because these products have evolved so quickly and are so broad and deep in terms of content or contamination that the cart is so far in front of the horse right now. Yeah. And I know I may sound like a nihilist sometimes but I'm not. I mean, I think, again, from a basic science perspective, I do believe there's something there, but we haven't come up with the product that that is controlled, evidence-based, not contaminated. I mean, Sativex, which has been around for a long time as well, isn't available in the United States, but it's already failed.
It is here. It is
At
here.
least 2 phase 3 clinical trials in cancer pain patients, that adding Sativex, which is a natural non-contaminated pharmaceutical grade cannabinoid with a nearly 1-to-1 CBD THC ratio, it's failed in the cancer pain patient population. So we don't even have it available in the US because it's not proven to be what people say it's going to do. And there's all these little articles that come out periodically that are small numbers, short duration, high risk of bias, and then it gets to the attention of mainstream media, and they're like, oh, look, it's this, like you said, a panacea. It's curing cancer, it's curing seizures, curing our opioid crisis, and what else is it? I mean, it's an amazing thing if you believe everything that they say, but when you really, when you tease it all apart, it falls completely flat. And I think things like the purified CBD, and actually the people from Alabama that developed it and got it through the FDA wrote my chapter in my book on seizures. I mean, it's a very well done book and an all-star cast, and it was one of the best chapters in the book, in my opinion. But actually, at this point in time, I mean, the data continues to evolve and change, and that's why I think we need to pump the brakes a little bit and say, okay, timeout. Am I a fan of more research? Absolutely. I mean, keep doing all the research that we can do, and but right now the mountain of harm in the research world on cannabinoids, it certainly transcends any real benefit or any perceived benefit. The harms are so great, and they're changing every day because these products evolve every day. I mean, the products that I can go in the dispensary today didn't exist 5 years ago. And so what's the scientific basis, and what's the dosing of shatter or wax or a dabbing? And to be honest with you, as a clinician, combustion isn't a good delivery mechanism of medicine.
Who knew? Who knew?
Who would have known?
Inhaling stuff,
Right. And things that like, for example, in some states, there's no cap on the amount of butane that's left in butane hash oil. I mean, when I was on the governor's task force, we tried to put a cap on it, but we were steamrolled by the industry saying they don't want a cap on inhalant that is combustible, but you're still going to heat it to inhale the vapors and stuff. So, I mean, until the data is clear, I think and the research continues, we just need to stop and just say, okay, well, maybe there's something there. Let's do the research. Let's put it through the proper drug development protocols, and give me a product that's been proven to be effective, that's not contaminated, goes head to head with codeine or oxycodone or what have you, and to proven to be superior. I'll support that 100%. But right now, there's nothing there.
Of course, I think again, it's interesting that the medical side of this is really important. Now, we presented at a national Senate inquiry into legalising cannabis for recreational purposes across the country last year, which we knew was coming, and we sort of coming about 6 months out. So we did a fairly extensive paper looking at every aspect of cannabis and its harms, and again looking at the potential for its clinical and its therapeutic benefits, and the failings that continue to emerge other than a PDLX. And we certainly want to celebrate a substance that is properly clinically tried. And one thing that was interesting, the gentleman who actually tabled the bill was he's a pro-cannabis activist. I won't say which party he's from, but it's from a very, you can imagine what sort of political party he's involved with. And he was saying, look, this is right. And he kept badgering me, and he was quite agitated. And I've got to be careful what I say here, but what I found was when I'm dealing with pro-cannabis activists, even whether in politics or whether in conferences, they always seem really hyper edgy, and it's really, this guy was really quite agitated, and he was going after me saying, "Do you believe that cannabis is medicine?" And some have said straight out, "No." I said, "No. I said, I think there is clearly some therapeutic capacities in cannabis. We've got some of those on our PBS, including Sativex and Naranol, and I said, so yeah, I understand those, but they are not. They are purely symptom alleviation, not curative in any sort of form. So that's fine." I said, and I have no problem with medicines that are properly clinically trialed. I said, "What about all these papers that this medicine does this and this medicine does?" I said, "Hang on a minute." I said, "I have no problem with double-blind, placebo-accounted for, evidence-based clinical trials, peer-reviewed. But what about this? And he just kept, what you mentioned before, rattling off these little studies off on the side, done by, and often funded by the industry, to produce a certain outcome. And it's just appalling. And so we've had, again, 40 years of this, hype. And again, all the research is now basically, the gloves are off. You can do whatever you want now, and everything's on the table. All the experimenters are still experimenting. Self-medicating people are still self-medicating with their own variations and tinctures and whatever they can get their hands on to magically say, oh, I feel better, so I must be better. That's kind of the now we're living in that. We've gone back to the 1840s. It's like, oh, if I feel better, I am better. This cocaine cures everything. Snort cocaine, I feel fantastic. It's like the madness, what I call the new reefer madness, is everywhere. It's just prolific. And when you have academics and politicians are parroting the same insanity, and you call it out, this is the new reefer madness. So I am fascinated to hear you, and I think our listeners need to hear it as well. As a clinician, as a doctor, as a scientist, you are clearly keen to see the best potential for this thing to be realised, for the best practice of medicine possible. But if it can't be, then this needs to be discounted and discarded. Is that a fair assessment?
That's completely fair. And the other question I've always, to your point, and I've gone toe-to-toe with cannabis activists and people that are very pro-marijuana, and they get very visceral. They really get upset when you don't agree with their point of view, and they can't even agree to disagree. They just get so irritated. So, I think the other thing is I haven't been able to come up with any medication that I can think of that's also recreational. There isn't that I can think
there
of.
It is.
I mean, I think some people, so how would you approach it when you flip the coin and say, okay, well, alcohol, if I drink a pint of vodka, my pain is better and I'm more relaxed. Well, that's just not a good, healthy choice for the patient. Or,
Correct.
You know what, if I lose weight and I'm less stressed if I smoke, a half a pack of cigarettes a day. I mean, again, that's just not a healthy choice. And it's you know this, Shane. I mean, the legal drugs we already have been a disaster from a public health
Correct.
perspective. Alcohol, tobacco, opioids, they've been a complete mess. And now we're just simply adding another addictive substance and an addiction for profit industry
Correct.
to the mix. And they all play well in the sandbox together. I mean, I'm sure back in the 1600s, some people died of lung cancer because of tobacco, right? But lung cancer really didn't become a problem until mass commercialization and marketing of cigarettes. That's when it became a problem. And this is just following the same playbook. And that's what I can't get that point across to my colleagues. I mean, honestly, for many years, I really felt like an army of one. I'm like, I was giving grand rounds at hospitals. People and my colleagues were disagreeing with me. I was trying to talk to the local newspaper, to the TV stations. I go, what am I missing? If I'm the only one saying something and my colleagues are not, and one of my friends here in town, who's a local businessman, and I use this quote very often. He told me that the public, keeps their eye out. But what made the most noise is when the doctors said nothing. I mean, they weren't coming out and saying, hey, we have cardiovascular effects, or we got in utero exposure issues, we have pediatric and adolescent addiction issues, or pediatric exposures, et cetera. Nobody was saying anything. So the public's like, well, if the doctors are cool with it, it should be fine.
There it is. And there it is, right on the money. And the idea is about recruitment. And of course, we know we've done ads as well. We've harnessed the ads from the 1950s and 60s of the tobacco industry, and more doctors prefer Camel. More dentists think Camel is better, or whatever, west of Chesterfields or whatever. And not just actors, but actually supposed clinicians are saying this is good for you. And I still, as scary as this is, a long time ago when I was young, decades ago, I worked with a guy who was prescribed a packet of Marlboro cigarettes a day by his doctor in the mid-60s for his stress. He was prescribed that. Because, again, what happened was the medical industry was bought out by big tobacco, and they were just steamrolled with faux evidence. And now what has happened now is silence. But also there you've got activists in the doctor space as well, cannabis users. So when they're promoting it as well, you've got this conflict. And I've seen both in operation in the public square, those who are against it because of the evidence and science and saying this is madness. This has no clinical benefit. This is actually a wrecking ball for public health. And those who are pro going, no, this is what we're going to do. How dare you? And of course, people listen to what they want to hear. And willful ignorance is always fed by propaganda. And so, this is what we're seeing. But we are seeing a shift. We are starting to see a shift, Ken. And kudos to you and others like Dr. Karen Randall in Colorado as well, who stood up in the midst of some pretty hairy environments as well and pushed back. And I think there's starting to get some momentum here. We just saw 3 states in the US vote down legalising for recreational purposes, which is fantastic at the ballot box. So that's a really good sign. Others are starting to revisit this. And of course, we saw Oregon reverse its decriminalisation policy on substances. Because all we know is that every permission model, regardless of whether it's decriminalisation, legalisation, whatever you want to give it a title, every permission model increases consumption. And consumption of an addiction for profit substance is going to only drive more profits and more marketing and more addiction. And this simple equation escapes politicians who maybe fed the line, and this is where I want to talk about the vote for medicine culture, fed the line that, you'll get revenue from this. And we did it. I watched this when California did this, and I did a paper about 10 years ago called Now There Were Three Markets. You got the legal, you got the illegal, and you got the grey market. And regulation was supposed to be removed. Policing was supposed to be removed, and now we've got this several levels of regulation that don't work. You've got 3 markets in play and chaos. So the Vote for Medicine platform obviously created a nightmare. So let's go there. When it comes to, again, what we just talked about, the public perception, the drivers, the public noise being made and the social media activism that goes behind that, do you think, and there's a lot of evidence to this, and I want to get your perspective on this as a pain management clinician. Do you think this is all added to the placebo effect of weed?
Well,
and the vote for medicine states?
The answer to your question is, the short answer is yes. And I think, studying a plant that has multiple components is very hard. It's hard to do the research on a botanical that has as many active components. And back to your comment on a lot of the legalization efforts have failed in the U.S. in the past week, despite the amount of money the industry threw at these ballot initiatives. For example, in Colorado Springs, where I live, it's the second largest city in the state of Colorado, and we defeated legalization of cannabis last week. We're the second largest city in the entire state, and we don't have legal weed because we know. I don't know. I don't think I have anything to do with it. Although I've been active behind the scenes with our mayor and the newspaper and et cetera. But the TV stations don't want to talk to me, even though they have an international expert in their backyard. I throw myself at them, and they completely ignore me. So
wow.
I think your point is that the amount of money in this industry and the people that are bought off and promote this, especially from a tax revenue perspective. I mean, I think our state leaders can't spell P&L or profit and loss because they all they talk about is the profit. And we know that all these other industries that are a public health disaster make a ton of money for their respective industries. But like, for example, the tobacco industry is losing market share with the vapes and to marijuana. So therefore, what are they doing? They're investing billions of dollars in the marijuana industry because they want to keep market share. So this is all about the money. The public health costs are already on the rise. I mean, I think you're aware of my paper I published several years ago that one medium-sized hospital in my community lost $20 million between 2009 and 14 just from marijuana-related ER visits. And you take that across the 25 emergency departments in the state of Colorado. Hypothetically, that's a $500 million price tag in negative money, $86 million a year, and it's just gotten worse. I don't have the bandwidth to do a follow-up study. I wish somebody would, but that's awesome. $83 million a year to the state of Colorado, where they're saying, well, we made $200 million in that 1 year. We then take another 83 off of that. And then add into the driving fatality data.
Yeah, that's just one metric. Yeah, exactly.
It's one metric. And actually, from a public health perspective, marijuana has failed every single metric of public health. Every single one. It's just a complete public health disaster. And I don't know why, just the in utero data alone should cause people to say, whoa, we need to step back from this. because of the data that's coming out. But like the ABCD study, for example, that is doing very good long-term follow-up on about 12,000 people, young adults now and adolescents that were exposed in utero, that they're having problems.
Yeah.
You know, and actually I looked at some of the data from the other substances. They don't have the in utero exposure negative outcomes that marijuana has. It just seems to be worse. And I don't know why people aren't going, wait a minute. And then the environment is a whole other issue. You know, we've got some environmental damage that it costs in the billions and billions of dollars that nobody is paying attention to and completely ignoring. And that's why it's been frustrating for me.
Oh, look, I share your pain. I mean, it's staggering. I was mentioned one day walking through a shopping mall in where we live, and there was a young activist for the World Wildlife Federation spinning around in her fatigues and her dreadlocks, and she said, "Give money for the wild." I said, "Okay." I said, "You stop smoking weed," and she looked at me and said, "Well, how do you know?" I said, "Well, clearly you do." I said, and then went into a tirade, a diatribe on what weed does to the environment. And she looked at me and just walked away, because it was like the cognitive dissonance, obviously, with the new reefer madness is crystal clear. People cannot put two and two together because they're just so enamored with whatever this is. And it is breathtakingly frightening in one sense. It's laughable in one sense, but as you said, you're looking at this here going, we're going to be paying the price, culturally, the price for this for generations. And Professor Stuart Rees is also a part of the Delgado Dart Group. He's done some incredible seminal work, as I'm sure you're aware of, Ken, on the genotoxicity and neurotoxicity of cannabis. And we were at the 2023 C&D as well, presenting on that, along with Professor John Tubaru on what it looks like on the ground from a social impact on young people. And so, again, the science is just irrefutable in this space. Yet we've got this whatever this is, but again, the propaganda machine works well. But people are starting to slowly catch up. In Australia, of course, we had our quit campaign for tobacco, which I think is ironic, and we argue this in the public square as well as in the political square as well, that we have three substances in our national drug strategy. We have alcohol, illicit drugs. We have one message, one focus, one voice for tobacco in all the public square. Education, media, it's quit. There's no other option. Comes to alcohol, it's moderate, be responsible. When it comes to illicit drugs, it's keep using, just don't die. Keep using, just don't die. So that's a cognitive dissonance in that space. And of course, with each permission model, as we've seen an increase in harms, with our tobacco model, we become until recently, one of the world's leaders in the lowest daily smoking rates in the world. Whereas 35 years ago, when I was a young person, 40 years ago, they were smoking in aeroplanes. You couldn't go to a pub without being a cloud of smoke. And now you're a leper if you smoke cigarettes, but if you use cannabis, you're a cutting edge person who shouldn't be stigmatized. We won't go down that road today. But look, I'm interested too in another side of this argument, because we talk about pain, cannabis being a pain reliever. And pain, a potential pain reliever, it's touted as this great panacea for this particular ailment, this particular arena of human distress. Clearly, it's not working in this context. But as a pain dispensing or a perpetrator of pain, I'm interested in this because I've been watching for a while, and I think you've been tracking this well. And I want to drill down into this a bit and pick your brains, Ken. What physical trauma, including road trauma, violence, murder, suicide, is being perpetrated on the community because of cannabis deregulation and cannabis liberalisation? Is this something you're aware of, and what's it look like in your space?
Are you talking about some of the higher potency problems and psychosis?
Yeah.
Oh, yeah, absolutely.
Particularly high in THC, yeah, of course.
Yeah, well, I mean, the data out of Europe, they consider anything more than 10% THC as high potency. And I don't know if they're testing sufficiently in Europe or anywhere else in the world in terms of what is high potency. But 10% THC really doesn't exist in Colorado anymore. The average smoked flower is about 20%, and then
correct.
The concentrates are 60%, and then you get into the dabs, waxes, and shatters of the world that are 85, 95, some claiming 100% THC. It doesn't even look like
I've
a plant.
seen that, yeah.
You know, when people start coming back, well, it was in the Chinese pharmacopoeia and found in Peruvian mummies, I go, well, that product doesn't exist anymore. You know, I really don't have a problem with that, 2 to 4% THC as much as I do with the 95% dabs that, just I tell people go to YouTube on how to do a dab, or go to YouTube and look at cannabinoid hyperemesis syndrome and watch people puking on, I don't know why people are that stupid. They record themselves puking after taking a hit on a dab rig, but there's a lot of dumb people out there, I'm sorry to say. That's
And
just,
only getting dumber on weed.
and that's the problem, is the target organ is the brain. And that's what I kind of approach when I do these types of presentations. And I talk about the brain as the primary target organ. So somebody's using cannabis for their pain problem and it's not helping because they still want their opioids. But what damage are they doing to their brain? I mean, the data is showing a drop in IQ over the chronic users over long periods of time. And you and I are both old enough to remember when they removed lead from lead-based paint because it dropped IQ by 4 points. And the data, depending on what you read, is anywhere from 5.5 to 8 points drop in IQ with the chronic user. That's getting no attention, And then the brain in utero, I'm going to circle back to again, is the target organ. So these babies that are being born are dumb. They're having social issues. They're not doing well in school, and they're having violence and all this other stuff. But it relates to the higher products and the psychosis that's out there. I mean, I have a small compilation on my computer of toxicology reports of these very horrific crimes, and there's only one thing on the toxicology is THC.
Wow.
And so I'm trying to sound the alarm on this. It's like, and again, I know I sound like a nihilist, but at the end of the day, I'd rather be wrong over time than right, because if I'm wrong, I'll just crawl under a rock and disappear, and nobody will give a crap who the hell I was. But doing this for over 15 years, I have not been wrong. I like being right. Everybody likes to be right. But I'd rather be wrong in this space, because I have evidence of mass shooters or horrific stabbings and, people getting shot in the head and beheadings, all related to cannabis. It's like the girl at the dance nobody asked, but she's at every single dance. Nobody's asking her to dance, but she's just there all the time. I can't, the data is so much debate on, does cannabis cause psychosis? Or is it just a correlation? And I know the correlation is very strong, but I do think that somewhere in there may be a causal relationship. It's multifactorial. There's genetic predisposition. There's all these other factors. But why is it at the dance every single time that you see a horrific crime that's very unusual? I mean, alcoholics kill people by running them over. They do get psychosis, but cannabis has the highest conversion rate to psychosis of all substances, including alcohol, including illicit substances. It's like it's over 45% conversion rate to psychosis. And when people become psychotic and they lose touch with reality, they do things they don't normally do. And so when you hear about these weird crimes and these horrific crimes, the first thing that crosses my mind is, did they do a toxicology? And a lot of the states in the U.S. aren't even doing it because it's legal. They just ignore the testing for cannabis. Even in a very horrific crime, they stop at alcohol. Well, they're positive for alcohol, we're done, and they blame it all on alcohol. And that's kind of I'm trying to sound the alarm on the fact that it is going to get worse because these products are continuing to evolve. And I don't think that the percentages are going to stay the same. For example, like if you had a 10% product and 1% of people become psychotic or 1% get addicted, whatever number you want to choose, just by sheer volume of more users, you would think that percentage would remain the same, but it's not. And I think part of it has to do with the potency, because back in the day they said, well, an adult user, it was a 9% addiction rate. That's the Degenhardt data from the 1990s. But now NIH and NIDA are saying that the addiction rate is 30%.
Yep.
Now, so it's not 9% anymore. It's 30%. And actually the data, and I used this presentation, the JAMA Pediatrics several years ago, showed that the early onset users of cannabis compared to their cohorts using opioids early onset, that cannabis users actually have a higher addiction rate at 3 years, even though the addiction rate's about the same. 3 years later, cannabis has a higher addiction in the early onset users. But you know what the biggest predictor of an early onset user is in utero exposure.
Of course,
I mean,
of course, yes.
That we're creating, and that's what bothers me. I mean, I can go on and on, as you know, in all these different spaces, but if you're just circling back, saying, is it really a good medicine? Well, any of this data would be pulled off the shelves.
Of course.
Because I've done PubMed review literature searches and to see, well, is this data with cannabis the same with alcohol or cocaine or methamphetamine or heroin or whatever? And I'm not finding it. A lot of this data seems to be very unique in the cannabis space, and that's why I'm concerned. Even despite the fact that I think there is something to the plant, and that's what it's like. I'm fascinated by it because it's like you can't not look. Right? It's like this train wreck in slow motion.
Yeah,
we're watching it happen, and nobody's doing anything about it. And that's why I continue, and that you continue to do what you do, is because we're just sounding the alarm. And honestly, at the end of the day, I think we're on the right side of history. Again, I'd rather be wrong, but so far we haven't been wrong. That's what bothers me.
I think that's important, the distinction there, Ken. I think for our listeners and anyone in this space, who wants to be the naysayer? Who wants to be the noisy, clanging gong in the symphony of weed promotion that's being so beautifully played? It's like, will you shut that guy up? Just shut that guy up. But I think people that were tone deaf are starting to actually be attuned, and they're going, hang on a minute. And you're right. In the in utero stuff, this is the cyclical problem that's going to keep reinventing itself with each generation, and the epigenetic shifts that are going to happen in people is going to be staggering. And I think we're not doing this because we're some sort of moralist, ethical, naysayers and killjoys. It is a systematic and intentional look at what's happening in the public space. In fact, our organisation has got a 160-year history. Now, of course, 160 years ago, these substances were around, but not, certainly not in the concoctions and iterations that they are today. But alcohol was the big problem. And there was a group, I don't know if you've ever heard this term before. You ever heard the term wowser?
No.
You ever heard the term wow? Okay, it's an Australian term. Oh, you're a wowser, right? In other words, people are having drinks, they're all getting stuck in.
That's about it.
Sorry?
I've heard of you're a wanker, but that's about it.
Oh, yeah. That's an Aussie term. And the Poms call it tosser. The wanker's an Australian one, yeah. No, the wowser. So it was a pejorative term given to someone who was not drinking as hard as everybody else or didn't drink at all. You're a wowser. But what they didn't realise, they thought that was some sort of slang name, but what the term stands for is an acrostic. We only want social evils rectified. Wowzer. And this is what we're still in the same game. And we tell it to politicians, they go, oh. And then I ask them the question, so you don't want social evils rectified? Oh, we do. I said, well, you're a wowzer too. Why don't you get on board, So the idea is there's got to be that alarm. And the alarm's got to keep being sounded. And as much as like car alarms at golf in the street sometimes, they just keep, someone's forgotten to. After a while, they go, hang on a minute. No, I can't just tune that out. I have to look. And that's what we're doing. And I think a lot of people are starting to look now. And with work that you're doing, obviously you had Stuart Reese, John Timberoo, and many other, Karen Randall, many other clinicians and scientists of high repute and incredibly well published are doing, and including specifically your the academy you're involved with. It's brilliant stuff, Ken. Before we finish up, a couple of things I want to just promote your book. Tell us about your book, Ken.
Cannabis
the one you published on, yeah.
Yeah, it was I think what got me started is, you can go to PubMed and you can Google whatever you want. But when I got the idea to publish this book, it really was kind of setting a new benchmark, because there isn't a good compilation of data in one book that some people like to read, medical textbooks. And so it was, a year, it was, 70 authors, 24 countries, 20 chapters in a year and a half of my life I'll never get back. But I think it was important to put that in a one-stop shop, because it really isn't about this is the most current data. Because I mean, the data that's in there has already evolved since then, because the book was published in 2020.
That's
But
right.
but honestly, if you go back to people like, I don't know if you've heard of Peggy Mann.
No.
Peggy was a journalist in the U.S. in the 1980s, and she published a book called Pot Safari, and she went as a journalist to the leading research of cannabis around the U.S. and Mississippi and California, and she put this little book together. It's a very easy read, and she actually got the Congressional Medal of Honor in the U.S.
Wow.
for drug education. And then, unfortunately, she passed away from cancer in the late 90s. But I got a hold of her book. You can buy it on Amazon. It's like $10 or $15. It's
Yeah.
pretty easy, cheap. And I read her book, and I'm like, wow, everything in her book is in my book.
Yeah.
I was like,
Nothing
I thought
new.
huh?
Nothing new under heaven, mate. It's
I thought I was really cool and smart, but I'm like, I'm not cool and smart.
Oh, you are.
I just compiled everything that's already been known.
Yeah. Yeah,
And so
exactly.
even though the data has evolved since then, the point of every chapter in my book remains the same and has remained relevant for decades. And
Absolutely.
actually, I was able to connect with Peggy's daughter, Betsy, who lives in France, and she's trying to get Pot Safari republished. And actually, if you Reader's Digest, I'm sure you've heard of that, back in the 70s and 80s, Peggy's work on marijuana was the most read information of every single thing that was ever published by Reader's Digest. It was just
Wow.
amazing. That's why she got the Congressional Medal of Honor.
Yeah,
She
of
was a
course.
woman. And actually, in my book, I had a dedication to Peggy and anybody that was impacted by any loss from any substance, and not just marijuana. It included marijuana, but the people and the families I'm sure you have met that were completely destroyed and turned upside down, either directly or indirectly related to that person's marijuana use.
Yep.
And so I
My-
think part
my
of
family
it
included.
was to people and families that have lost a loved one to substance use. That includes marijuana. And so the early researchers like Dr. Carlton and Peggy Mann and all these people that were doing exactly what we're doing 40 years ago, but bless their heart, they were not. They didn't have the capacity to make the sound as great as we are now because the needle was moving. I mean, I have some very libertarian, very liberal friends here in the community that were, they were always getting arguments with me about this. And now they have buyer's remorse because my friends that are liberal here in Colorado Springs tell me, if I had only listened to you
Wow.
before we legalized, and the things that you said that are coming true, I would not have voted for it.
Yeah.
And so I think you hit the nail on the head earlier when you said the pendulum is swinging. I think the needle is moving because people are starting to realize why did all the states in the U.S. fail despite the most amount of money went into Florida. That's the most money that the industry pushed into any state in the U.S. was in Florida, and it failed because I think people are starting to wake up. And they're starting to see what's happening to their families, their communities, their children. And despite the fact that, again, this sounds very reefer madness, very nihilistic, and I want to circle back because I think there's something to the plant that may have value.
Of
and we
course.
have things that are there already, but we can't just give it to the public without knowing what it's going to happen, what it's going to do to the public. And we're
Correct.
only
Yeah, the vote for
now.
medicine.
And the black market weed in California that's tainted ends up in the dispensaries. People don't know about this. That the contaminated stuff is in the dispensaries that are quote legal, but they're covered in pesticides and fungicides and all these other poisons, heavy metals, because people don't realize this. And that's why I keep doing what I do.
No, and brilliant, Ken. And what's your book's title again, and where can we find it?
Cannabis and Medicine, an Evidence-Based Approach. You can find
Perfect.
it at Springer, which is a medical
We've got it here. Yeah, it's a brilliant book.
Springer, and Amazon. You can get it on Amazon.
Perfect.
And you have the book, right? You read it?
Yep, we do. We do.
Did you get in my dedication page? There was 3 points in the dedication page.
I probably skipped that because I'm a researcher, so I do apologise.
Check it out. Well, I'm not gonna.
Right.
I'll give you what it meant. So I part of my dedication page was to these families. The other part of my page was to the physicians that are do no harm. It was a quote, the Hippocratic Oath, do no
Correct.
harm. And the one thing that no one's ever called me out on is a reference to the Trojan War, because this has been the biggest Trojan horse of all time, in my opinion.
Absolutely. No, absolutely. Couldn't agree more on that. In fact, as you said before about families and impact, I mean, there is, for every marijuana user, there is or cannabis user or drug user for that matter, there is a family around suffering. Sadly, I buried my younger brother earlier this year. He was a long-time cannabis user. He was on disability as a result of his cannabis use, and he was government funded. We have a national disability scheme here, which is brilliant, and it's free healthcare and free support and free housing and free everything for people who are mentally ill. And what they've done here in the bad actors in our culture who've got control of policy levers have about 10 years ago collapsed all drug using impact data into the mental health data space. They've made it all one. So drug use can't be called out. We've destigmatized it all because you can't. No one in any space that I've ever worked in ever has celebrated or condoned the abuse, mockery, or maligning of drug addicts or drug users. However, we've gone to the stage now where you say, "Hey, dude, that's really harmful for you and others. How dare you stigmatizing me?" So now we've got this new speech code in place, and now we've actually collapsed all the data in. So we've got this growing mountain of drug schizoaffective states that are drug induced for the large part, and now they're getting absolute support from free medical and housing and everything. And my brother was one of those. Now he was off the weed, fortunately, before he died, but his body was so broken because of his long-term use. He simply went on, lied down on bed, and the toxicology report came back. He was completely healthy and clean, but they still don't know what killed him. His body just failed. I just watched him turn into a...
That is exactly why I feel that cannabis is so insidious and covert. Yep. Because people like Laura Stack, who lost her son Johnny from suicide,
of course,
he had cannabis psychosis, but when he died, he was negative. He didn't have cannabis in the system, and that's why it makes it so hard to determine this link, because you may be negative, and sometimes they don't stop. They don't do hair testing, which they probably should have done, but that's what makes it so covert. And the data from Denmark, I mean, as it relates to psychosis, schizophrenia, I mean, if 30% of men, 50 million, 6 million people, 50 years or something like that, that the male schizophrenics may not have developed schizophrenia if they avoided cannabis use on a frequent basis. So the link is there. I mean, the correlation is so strong. It's like, when does it reach the tipping point where people say, you know what? It causes these problems.
I'm going to call it. Yeah,
I refer to Occam's razor. I mean, what's the most logical? What's the most logical answer?
Absolutely.
There it is, staring us in the face.
Yeah, I think that's a classic. But that's what happens when you want spin. Spin's always about taking the obvious, the clear, the pragmatic, epistemologically sound outcome, and having to spin it another direction because I do not want this outcome. Ken, just before we go, we ask 99% of our guests this question, and we ask you as well. It's a question without notice. Fence or ambulance when it comes to drug policy? Fence or ambulance? Fence at the top of the cliff for prevention, ambulance at the bottom of the cliff for damage management.
Oh, I think the prevention is the best harm reduction tool ever.
Correct.
But they don't talk about prevention. They just talk about mitigating the problems, and they talk about harm reduction and let them use, but let's reduce the harm. The best harm reduction tool is prevention, period.
Well, I love your answer. And again, unrehearsed. I appreciate that, Ken. Our motto, of course, for Delgado Institute is 150 years of minimising harm by maximising prevention. That's our mandate. Dr. Ken Finn, it was an absolute joy having you. And look, we could have talked for a lot longer, but I think what you've done and the resources, again, the books and Pot Safari, again, we just want to promote that. I wasn't aware of that book, so I've learned something today, Ken, from a lot today, Ken, but obviously a little bit more than I expected, so wonderful. But I encourage our listeners, just drill down to what Ken's talking about. Look at his research online, visit his clinic, well, not personally, but check him out online. The guy is... and I'm going to blow his trumpet for him here. The guy is an expert in this space and someone that should be listened to. Dr. Ken Finn, thank you again for joining us today. And until next time, we'll look forward to seeing you here on the Unnecessary Harm podcast. Bye.
Thank you, Shane. Appreciate you.
As we wrap up today's session, remember, each step towards understanding is a step away from unnecessary harm. We're here to empower, inspire, and pave the way for optimal well-being. Stay resilient, stay informed, and continue being the change your community needs. Thank you for joining us at the Unnecessary Harm Podcast. Until next time, take care and keep pushing forward.